excited to say we've gathered a great panel of experts with diverse backgrounds. We have Dr. Stella Kang, a radiologist and researcher from NYU Langone Health, who's with us. We are awaiting Dr. Chris Moore, who is an emergency department doctor and also a researcher from Yale. Unfortunately, as a ER doc, he has a lot of last minute things that may keep him from this webinar, but hopefully he'll join us in the middle of the webinar. The ED is a great source, a big source of imaging orders to radiology departments. So we were looking forward to getting his perspective, not only as a researcher in this area, but also as a leading referring provider perspective. And last but not least, we have Andrea Barondi-Kitts, who is a retired engineer and a very passionate and prominent patient advocate. And in my previous conversations with Andrea, I love to hear about her engineering approach and her systems-based approach to her patient advocacy work. I'm sure she'll communicate a lot of that in our discussion. So this webinar is really building upon the great work that these panelists have performed recently. And I just want to mention a couple of them. Dr. Moore led and Dr. Kang co-authored a American College of Radiology and American College of Emergency Physicians white paper on, and I'm going to have to read the title because it's pretty lengthy, Best Practices in the Communication and Management of Actionable Incidental Findings in Emergency Department Imaging. And that was published in the Journal of the ACR in March of this year. And then Andrea has performed some great work in conjunction with the ACR Data Science Institute on patient-facing AI use cases on incidental findings. We've placed the links to these articles in the chat window. Before we begin, I want to give a special thanks to the ACR for making today's webinar possible. Our format is going to include brief introductions from our panelists, a roundtable discussion that I'm going to moderate, and then we'll open the floor up to your questions. So please submit your questions in the chat room, and we'll take them as we get them. Without further delay, let's get started, and I'll ask Dr. Kang, do you want to lead off here in terms of an introduction, and then we'll turn it over to Andrea. And if Dr. Moore joins us in mid-flight, we'll continue. We'll make changes to the schedule. But Dr. Kang.
Absolutely. Thank you, Steve, for the introductions. It's really a pleasure to be here on this webinar on this very important and timely topic. So I thank you for this opportunity. I am a researcher. I'm a health services researcher specifically, and I have found that it is just a privilege to work in this space because it is the intersection of things that matter to us as physicians. The patient perspective and experience, quality of healthcare, the effectiveness of the care that we deliver, and so on and so on. And so when we're talking about healthcare delivery, I've tried to think about how, as a radiologist, we might extend past that traditional line that has been drawn with regard to releasing a report to somewhere out there, right, into the ether and hoping that the appropriate steps are taken. And I would say I've never, looked back in terms of my decision to be an abdominal radiologist. I've loved it every step of the way. And if anything, I would say a lesson that I've learned is that I wish I had taken even earlier chances to develop an appreciation for quality improvement, right? And really the epidemiology around these actionable and unexpected findings and how to better provide care for them. And with that, I see that Dr. Moore has joined, so I'll hand it off to him. Thank you.
There you go. Nothing, he had an emergency. So we're happy to have you join us. And I've already sort of done a little bit of an introduction to you and some of the work that you've done.
Yeah, my apologies for being late with fellow interviews that ran over a little bit. So thank you for having me here. I've been at Yale for over 20 years, and I'm an emergency physician with an interest in imaging research. Done a lot of ultrasound, led me into CT, and we just do a lot of imaging in the emergency department, and CT is a huge part of that. And then that really led me into incidental findings, and I think the emergency department represents unique challenges for these important findings and making sure they don't fall through the cracks. So I'm looking forward to the discussion.
That's great. Thank you. And Andrea?
Hi, thank you for the introduction, and I'm really happy to be here and excited for the conversation. I'm a retired aerospace engineer. I spent 32 years working, developing, designing, and validating propulsion systems for military aircraft. My last 10 years was working on the F-35 aircraft, if any of you are interested. After I retired, my husband was diagnosed with stage 4 lung cancer. I spent a year and a half taking care of him and trying to figure out everything I could to try and, save his life. Unfortunately, it was a late diagnosis. So there weren't many options for treatment at the time. It was mainly chemotherapy. Targeted treatments were just starting to come in, and immunotherapy was like right on the brink, but not there yet. During my journey with my husband, I decided to become a patient advocate. Given my technical engineering background, I knew that what I wanted to do was bridge the gap between the technical side and the patient side. I went back to school to get a master's in public health so I could, get some technical information on the healthcare side. And my prime focus is advocating for people with lung cancer and advocating for lung cancer screening. I take a systems approach. I, talk to individual people, but it's really a systems approach. It's not up to the individual to do something to make it. We have to change the system. I got very interested in incidental findings because during lung cancer screening, it's a low-dose CT scan, and about 10% of the initial baseline scans have an incidental finding. That drops down to 2 or 3% later on. And there's a lot of discrepancy in how they're reported and the follow-up on that. So I'm looking forward to this discussion, and hopefully we can come up with some really important interventions and suggestions on how to improve the follow-up on these findings.
Right, which is a great segue into, first of all, a lot of the folks that are on this call, and we have a great attendance here today, are health system administrators as well as clinicians. So when we're thinking about this, let's start with characterizing the opportunity. Is there adherence gaps? How significant are those gaps, do you think? Is it impacting a specific group of folks or organizations? And it'd be great if each of you all could touch on that. And I don't know, Andrea, since you just were speaking, you want to start?
Sure. Yeah, there's a lot of disparity. Just like there is in all healthcare, there's a lot of disparity in care and in following up of incidental findings. I'll give you an example. I had a friend of mine that was a cardiac surgeon who decided he wanted to start a lung cancer screening program in Trenton, New Jersey, in a federally qualified health system based on my enthusiasm telling him he should do it. And he decided to start with incidental findings, incidental pulmonary nodules. So he reviewed all the CT scans that the hospital already had, and he identified there were about 70 incidental findings in pulmonary nodules that had never been followed up. So they started following up on these to see if they could track down the people. Well, there was one person that they were particularly concerned about. He'd had an incidental pulmonary nodule found in the ER, and it was at a late stage, and it looked like he really needed treatment. And they kept trying to get a hold of this gentleman and they couldn't find him. One of the nurse navigators said, well, let me go see if I can go to his neighborhood and see if I can talk to his neighbors and try and track him down. So she went, and the neighbor said, yeah, he lives here. And so she went in and she talked to him, and he said to her, he said, yeah, I've been trying to follow up. I've been to the ER 3 times and asked them about it, but nobody knew anything about it. So, we have to make sure that that we understand where people are coming from, make sure that they know about their incidental findings, and tell them what the plan is for follow-up. And there needs to be an approach to reach out and to follow up with every person, especially when the incidental finding is in the ER. There's more of a systematic approach when it's routine imaging, like in cancer screening. But the disparities that we see in all of healthcare with underserved populations definitely exist in incidental finding follow-up.
Right. And she mentioned a lot of ER in there, Dr. Moore. Do you want to comment on that?
Yeah, no, sure. I mean, I certainly view this as an equity issue. In fact, we're currently undergoing some work. We're funded by the Gordon and Betty Moore Foundation to look into developing an equity quality measure around this specifically. And there's varying data. We're really digging deep into our own data, but the follow-up rates on these incidental findings from the emergency department, some literature suggests it's as low as 30%, right? And these are patients who, the ones that use the emergency department do tend to be, the ones that don't have access to a primary care physician or things like that. And I do completely agree that this is a systems issue. You can't really rely on an individual emergency doc at 2 a.m. who's worried about a pulmonary embolism, that there's a little nodule and they're trying to discharge 10 other patients. That's something that needs to be followed at the systems level. And that's really the impetus behind the work that we did that was published in JACR. So I absolutely view it as an equity issue. I think there are definitely populations that are not getting good follow-up, and we need to do our best to try to fix that.
That's great. And Dr. Kang?
Yes, I fully agree with the points that have been made. I mean, I think the only other thing I'll add is that we know so many things about the populations that are disadvantaged and continue to be disadvantaged, right? We're aware that risk factors for lung cancer might disproportionately affect some of these folks, right? Who are not surprisingly then manifesting lung nodules, for example, as incidental findings. And we also know that language is a barrier, right? And so we're just at the beginning of understanding the impact of releasing reports directly to folks. And so it's sort of our responsibility, our duty to then understand how we can improve upon our initial efforts, right? By providing substantive information that is meant for patients to understand and to act upon, right? And so again, providing a closed loop in many, many more senses of that term.
And language is a big, I just want to follow up on one thing that Dr. Kang said. Language is a huge barrier. Not speaking English, there's a lot of healthcare situations where people can't even get in to talk to anybody. There was a recent article published in JACR where they basically went out to, I think it was like 44 different institutions, and they called in 3 different languages: English, Spanish, and Mandarin. In the English speaking population, in the English speaking folks that called in, 94% were connected to, they were trying to get some information on cancer, so they were connected to someone. In the Hispanic population, the Spanish speaking, it was 38%. In the Mandarin, I think it was like 18%. So that's just the first level entry. And then if you take a look at, okay, so let's say you get to the ER, or you get a diagnosis and you get sent home with this material written in English and you don't understand it, you have no clue. You don't know. Even if you go into your portal and you see that, you read your radiologist report and it's not in patient-friendly language, even if you speak English. But if you read your radiologist report and you don't understand it, it's not there, then you're not going to be able to follow up on it.
Right. And I think you did a report that said that 7.5% to 15% of radiologists of the referral providers are not even opening up the report as well, right? To place an order for that follow-up.
Right.
Right. I mean, I know that's a separate issue, but do you want to talk a little bit about that in terms of the challenge in adherence as well?
Right. I mean, so the referring clinicians are really busy. So, you know, if they don't even open up the radiologist report, then there's no chance of a follow-up. So there's that piece of it. There's the piece of consistency between what radiologists write. Even if you take a look at lung cancer screening and reporting incidental findings at a single institution, there was a report that was published recently at a single institution, there was so much variation in significant incidental findings reports that it was amazing. For example, they had 561 reports of coronary artery calcium that they gleaned from about 2,000 incidental findings. Out of those, only 4 had a discussion between the radiologist and the patient. Only 4.
That's interesting.
And the way it's reported is different. Is it reported in the impression? If it's reported in the impression, there was a higher probability that it would get acted upon. It was just in the general discussion, it wasn't.
Yeah, it's an interesting, you know, you all have mentioned the whole systems-based approach to being able to help close the adherence gap. And it seems like that is a general problem that we have with our healthcare system here in the United States. It's not specific to radiology or to ER. And there's a profound impact, obviously, on patients. So let's transition to more of the best practices for closing the adherence gap. One thing that we're seeing here today is that there are so many priorities that organizations have these days, whether it's tightening budgets, staffing shortages, IT initiatives. How do you go about justifying prioritizing this over these other things that are in front of organizations? Does there have to be clinical and business justification on this? Are there regulatory constructs which provide the impetus to put a follow-up management program in place? Can you all each touch on some aspects of that?
Well, certainly it's a quality issue. I mean, I think there is a strong business case that can be made for this, which helps, but it really should be about patient care. So, you know, there are economies of scale. I think this is much tougher for very small institutions. I think in larger institutions, you often may be able to combine this role with somebody who's looking at follow-up of many things. We often have a, you know, emergency department follow-up nurse or somebody like that. But I think, you know, justifying a position like that, I mean, there's medical legal implications. I mean, I've been contacted for several recent lawsuits where, you know, there's a missed incidental finding, and it's a large judgment. I mean, if they really miss something that should be followed up, and that's something that maybe the institutions will take notice of. So I think it spans that whole, you know, spectrum from quality to a business case. But you do have to make a case to do it, and you have to find the sweet spot at the institution with, you know, hiring a person who, you know, has the right amount of things to do and can make them happen.
Right.
Yeah, I agree with Chris. And I think that, you know, when we think about the calculus of how hours are spent and what providers and what physicians are doing with their time, right? It's not a fail-safe, far from it method of communicating. If we're making phone calls whenever we find the time and what occurs to us, right, to prioritize rather than having a very systematic and foolproof way of handling these things. And so the more we're equipped and using the technology that we have ready access to, the better. And in terms of, that's both on the business and clinical justification side. And the more we have someone who is assigned to a well-designed, dashboard or report or tool, right, just to make sure that we're prioritizing the lesions that are the most likely to result in medical harms, right, or some adverse health event, and making sure that we've documented and are trained, right, to make sure that we're communicating that risk very clearly and with a clear route to the next steps, the better for all of us, right, both in terms of the financial health of our system and avoiding bad outcomes, but also ensuring that the right patients are being seen at the right times to be able to intervene when necessary.
Yeah, I would think that, first of all, we need to make sure we leverage AI, because I think we're underutilizing AI, and that would help all sizes of institutions. I'm a patient advisor on a Stanford. We're putting in a PCORI Placer grant. And what we're taking a look at is enhanced notification of coronary artery calcium that's found by an AI algorithm on people who've had low-dose CT scans versus usual care, which is just sending guidelines on screening people for coronary artery calcium, screening people for cardiovascular risk. So this would be, so there's actually an algorithm that's FDA approved, several of them that have been developed, that can take a look at low-dose CT scans that are already in the books that people have already taken. This is a population that gets screened that is at high risk for coronary disease. We're going to be able to go ahead and scan those, find the coronary artery calcium, and then send a notification both to the referring clinician as well as the patient. And this is all basically going to be done as automatically as possible. So we have to make sure that we have a way of leveraging the AI. And, you mentioned the AI DSI use cases earlier. I would recommend that you go out and take a look at there. There are 3 on incidental nodules that we've had, on incidental findings that we have so far. One is on closing the loop on the physician opening it up. Another one is on triaging the findings. And the third one is the follow-up and closing the loop.
Right. That's interesting. I was wondering how long it was going to take us to specifically have somebody comment about AI and the use of AI. It took us about a third of the way through our webinar here today, but it does have profound effect on so much of what we're doing here today. Are there other models? Andrea, you mentioned one model, but are there other models for really successful deployments of follow-up management programs? These are not, if you're taking a systems-based approach, it's not one size fits all. It's not one product. It's not one solution. It's really something that requires a program over time kind of approach. That's what I'm hearing from you all. And from Agilon Health's perspective, this is not a commercial conversation. It's much more about educating the market, but it's one of these things where we're seeing that as well with each of the different institutions that we go into, all have different ways of doing it. So I was just wondering, like Dr. Kang and Dr. Moore, whether you've seen different implementations like what Andrea just referred to that were particularly interesting and effective.
There are lots of different ways of doing this now, and I can think of a handful that are really publishing, right, what they're finding and their rates of follow-up adherence, but many more variations of systems and informatics, of tracking systems specifically, are being implemented. And I think that, like you said, there's no one way that's right to do it, and it has to be adapted to the local environment, the resources, right, the patient population, et cetera, et cetera. And frankly, it's one of those things where it's ripe for AI to be right in there, right, to be facilitating with the clinical decision, for example, when popular application being studied is using AI to detect that something's been found, reported, and then to generate a pretty consistent communication, a phrase about the level of risk this entails and how to word the recommendation according to current guidelines, right? And that's a form of clinical decision support. How helpful would that be? We talked about the responsibility of the radiologist, right, to communicate clearly, highlight those findings that really merit follow-up, as opposed to inconsistent messaging about whether this is an option, is this consider this, or is this do this because it's a high-risk lesion? What are we saying, right? And then secondly, also just in tracking follow-up, right? If there's nothing that is detected in terms of either documenting that the physician is aware, but that for this particular patient, recommending an imaging follow-up test is not the most appropriate level of action, great, right? But there has to be means, and it's, you know, something that is very viable with regard to AI being ready to document a test that is or is not ordered, you know, along the due dates, as we say, for that follow-up to occur.
And the fascinating thing about AI is there's the first level is the sort of natural language processing on the reports. Like, do you find a report that has a follow-up and make sure that that gets flagged? You know, but the next level, which is really fascinating, is, you know, looking at the images themselves. And if we're able to, you know, have the AI augment and find things that radiology, you know, may or may not have missed, but either way, really sort of objectively determining what the risk is of these developing into malignancy. So I think that that's a long-term frontier, but I completely agree that, you know, AI is going to be a huge part of this, and it really can allow for systems approach. You know, structured reporting would be nice. It's been really hard to get that to happen, right? So as Andrea mentioned, you know, many times the radiologists put a recommendation in different places, and so that's part of what we focused on in the article that we've published, is trying to make sure people are putting the recommendations in the right place, and, you know, makes it easier to find them. And if people are willing to do structured reporting, and I think some places are doing that, and Dr. Kang might be able to comment more on how often that's happening or how hard that is to implement.
Well, in lung cancer screening, we have structured reporting for the most part. And even then, it wasn't structured enough to have it in the same place. I would just say one other thing about AI, and that is that we have to consider communication to the patient. We have to consider using AI to create patient-friendly language to communicate to the patient, because the patient needs to be part of this follow-up team.
And at what level do patients need to be part of this? Should they be seeing the entire report? And I'm saying separate from lung cancer screening, where they may be part of a lung cancer screening program.
Oh, in my opinion, patients should have the option to see the entire report. Every patient is not the same, so you need to have different levels. I've read lots of radiologist reports, and I personally want to read my whole report. I want to know it. I want to know before I go in to discuss my situation, etc. There's other people who might not, who might want just a layperson summary to tell them, okay, this is the basic thing that this report is telling you, and this is what you need to do next, and this is why, in easy to understand language. And if a person knows, hey, I have to go talk to my doctor because, oh, I have this nodule on my lung that may be nothing, but I should follow up on it, then they're more likely to go do that than if they don't have that information.
Right. Dr. Kang, you were about to say something.
Oh, no, I was just going to comment on the structured reporting. It's a start, and it's so important to provide what I think, you know, especially in the emergency room setting, is important, which is to be succinct, to be clear, right? To highlight the things that can't wait or shouldn't get forgotten once the patient is discharged and is already dealing with the acute need, right? The reasons they visited the emergency room. They can be discombobulated for a while, understandably, right? And so we need to have a system in place to do that. Yeah, and I fully agree with what Andrea is saying. I think about when we still attempt to use the AI, the chat bots, if we call into a customer service line, right? And that even often now includes the opportunity to give feedback. Was this helpful? right? And we're not even doing that when we release our reports en masse to patients. And so we're really a ways off. I think we have tools, and I know many people are working in this area, and really kudos to Andrea and all the people who are trying to get us to the level where we can provide something that is patient facing, and also then ask, right, what else can we do? What can we do to help make this clear?
Yeah.
The other thing I would say is that there needs to be an opportunity for patients to talk to the radiologist. Right now, there's many radiology practices that actually don't let the radiologist talk to the patient. I had a lot of imaging done in one of those in Connecticut. I couldn't believe it when I called in to ask a question. They said, "Oh, we're not allowed to talk to you."
Wow, I'm surprised. Okay.
Yeah.
I never heard of a prohibition on it. I mean, I know there's sometimes reluctance, but that's an interesting concept that probably shouldn't be in place.
That is interesting. One thing that would be helpful is with Dr. Moore and Dr. Kang. Can you all talk specifically? I'd like to, we're talking at a high level. It'd be great to hear a little bit more of what you all are doing at Yale and at NYU specifically in this area. I mean, Dr. Moore, as I mentioned in the intro, the ED is such a big source of imaging requests, right? And it's a very transient population. So what do you all have there in place today, if anything, that assists you with closing that adherence gap? And I don't
Sure.
want
Some of our stuff is in transition. I know we've looked at a few different systems, and there's different things that we're putting in place to flag. There's the different color flags, and we do have follow-up nurses that track findings in the emergency department and do keep track of that. But we are actually still evolving our final way to do that. I think I may even see, I think one of the participants here is one of the radiologists from Yale. He may be able to comment on that a little bit better than I can right now. But
yes, we've had a continually evolving system. And what we have for the ER specifically is that there is a manual review, right? And so we do have an informatics system where important findings or incidental findings that have a tracking system can be followed in a report, an electronic report. But again, this consistency is an issue, right? And so there has to be somebody who still is reviewing just to make sure there isn't something that's dropped. And even with that level of nurse review, right? Somebody who's knowledgeable about the significance of some of these actionable findings, we were still finding that there was a high rate of miss, right? Where for whatever reason, it wasn't clear to either the follow-up coordination nurse or, right, it was clear, and yet they had tried to reach the patient a couple times, and it was really hard, right, to make sure that that communication had taken place and that a plan had been formulated. And so the reports are there. We look for follow-up to be completed especially for important findings. And beyond that, we're starting to work on language models. I would say there's a pretty good concerted, multidisciplinary team that's looking at how to leverage the large language models to be able to just pick this up with, at as much as possible, 100% sensitivity.
Yeah. When you look at this systems-based problem or approach that's needed to solve this adherence gap, communications is such an important element of it. So you have to the radiologist first has to communicate that a follow-up is needed. And then that follow-up has to be communicated back to the referring provider. If it's internal to a health system like a Yale or an NYU, that's typically done through EHR systems and things like that, right? But how much of your referring provider base is outside of your health system, and what are the communications mechanisms besides like 1980s technology like faxes, right? We're still that's the predominant way to communicate these kinds of findings to these folks. What have you seen? First of all, do you know how many of your referring providers are external to the health system, Dr. Kang?
We did a look. We analyzed randomly selected patients with incidental lung nodules, and out of 1,000, I think we had 9% who we were able to establish had some sort of follow-up that was not documented at all. And we have care everywhere, right, where we can see what happens with other large New York academic systems. And so I imagine, that's what we were able to account for. So it's probably bigger, a little bigger than that, right, in terms of folks who end up going to see somebody else outside. When we have the level of an important finding that the radiologist has determined is important to mark, to flag that way, we've developed a system, again, consulting with a multidisciplinary team to make the phone call to the patient when necessary. When people have tried, they can't do it. They can't establish contact. We try to call the patient even ourselves, and then we'll send a certified letter just to make extra sure that the patient has the opportunity to receive that information.
Yeah, and Dr. Moore, sorry, go ahead, Andrea.
Do you find that a lot of your patients are not using your patient portal? Is that something that you use as well? I think sort of US mail is a good approach for a lot, but the patient portal, I don't know how many people use it. Is about 50-50?
Yes, I don't have a recent proportion because it was constantly changing, it was constantly going up with all the encouragement to, speedier communication through the portal. But as we have disparities, right? We don't have a perfect system of access even to cell phones or smartphones, et cetera.
Right.
Some people, might lose the ability to pay for the internet access after a while, and we don't know that. And so these are all imperfect things, but we've found that, like other things, mammography results, for example, US mail, it's something that we can send, and the patient can have something in writing that they can take to whatever provider that they can find access to, who will hopefully plug them right into a system where they can get the appropriate care.
And Dr. Moore, we were just talking about external communications, and I know you accidentally dropped off with some technical issues, but we were talking about external referring providers, those that are not within the Yale Health System, and how do you all communicate today with those external providers, if you know? And certainly in the ER, you see a lot of transient folks that may not have referring providers like primary PCP kinds of providers, right?
I mean, our system is, epic, and it's actually fairly comprehensive for our catchment area. It's pretty rare that we find somebody that doesn't have anything in our system unless they just traveled from Florida. But there are definitely, clinics and things that aren't as well connected. We do have also, care everywhere, and ability to interface with that. But it's certainly a challenge logistically to be in touch with, especially at all hours, right? To be in touch with the primary physician, and so that's why I think it's important at the system level to delegate this to someone who's really looking at the follow-up and can arrange that during regular business hours.
Right. So you all have a dedicated team to actually go do that. Is that right?
Yeah, we have nursing follow-up, people for the emergency department, so they deal with a lot of different things. Certainly not just incidental findings, but that is part of it. Yes.
And you also have, Dr. Kang, do you all have follow-up managers at NYU?
There are currently. I may not necessarily be up to speed on details of that system, but there are. Got
it. Okay, that's great. We are getting some questions coming in from the audience, and I would welcome more questions as you all are going through it. One thing that somebody asked was, who is the decision maker in organizations to manage this? So there are radiologists that are in the audience that want to promote it, but who should they reach out to? Who is the primary driver of this? Is this a radiologist kind of opportunity? Is this a chief compliance officer? Is this a chief financial officer? Who would be the one who's really the decision maker?
Well, it's certainly multidisciplinary, and I mean, most large systems do have, quality officers. I would say that's probably one of the main areas. I mean, there's a, as we've mentioned before, there is a business case, I think, more for radiology than emergency medicine. But I think as Stella said, it varies from institution to institution. But you should have somebody who, looks at this from a multidisciplinary level. I would hate to see it siloed in radiology or emergency medicine or one place,
Right.
because it's really, it crosses a lot of different care patterns. So
That's right. And having the data in hand, right, to understand where a particular system is with regard to success and getting the appropriate follow-up, and hence the importance of that tracking system and the ability to look at reports is so important, to have that data and to be able to understand what's working, what's not working.
That's great. Another question that came in was dealing with your research that you conducted. Each of you all have conducted different research, some of it with the ACR, but what are some of the most important insights from the research that you all conducted? So give your top 3 from each of your research that you've conducted. What would you want the audience to understand and focus on? So, Dr. Moore, do you want to
say,
go ahead.
oh, I'm sorry, go ahead.
There you go.
Sure. I would say one thing we haven't touched on as much so far is that thinking about the flip side, we talk about getting those risky lesions followed up and doing so reliably. But the other side of it is that I think people may not necessarily be aware that radiologists are thinking about over imaging and over testing and over diagnosis too. And sometimes we forget to message that aspect of it too, but we're very conscious also at the same time, not burdening patients and the whole system, right? And our busy referrers with unnecessary recommendations, right? And so where we think about effectiveness, I think a measure of unnecessary or overkill follow-up is something that
Actually,
we're also interested in.
That really dovetails. I mean, if I were to really crystallize what I'm most interested in about this is actually determining, when is this going to become cancer and what is the risk? Because if you can really quantify that for the patient, that's much more helpful. The Fleischner guidelines, which are typically used for, incidental findings, we found that on what we call conditional follow-up, where there's a risk factor, but otherwise don't follow up, we're looking at our tumor registry, and it's very uncommon that those develop into malignancies. So, that may be an area where we are actually, spinning our wheels and expending resources where it might not be as high yield as some of the other places we could put it. So I think figuring out those things is a very important research question that's definitely top on my list of things we're trying to do. So,
well, and I would think, building on that, Dr. Moore, I would say that having some standardized approaches to how you approach to what you need to do for actionable incidental findings. I know we have some of those for lung cancer screening. There's guidelines. ACR has guidelines for all sorts of incidental findings. So maybe using that kind of decision support to help go through and end in structured reporting, and using AI to help bring all that stuff up. Maybe one of the first steps to doing that, to avoiding over-treatment and over-diagnosis. For me, my top research thing is make sure we include the patient and make sure that it's meet the patient where they are from a language standpoint, and make sure that they're part of the team. one of the things the Institute of Medicine, when they talked about medical errors, a medical error is not just, defining the proper diagnosis, but also communicating it to the patient. And they want the patient to be part of the team. And in my experience, regardless of, of the level of interest of the patient or the patient health literacy or their education level, every patient deserves to be part of their team.
That's right. That's right. And sometimes, especially when our evidence is minimal, right? Or a lesion has some characteristics that doesn't necessarily put it in the definitively benign bucket and has a low level of risk, but there's uncertainty, right? Sometimes a shared decision is what you can offer, right? And to put that uncertainty into terms, maybe even a graphic or a tool or something that we should be thinking about, right? So that patients can really share and understand where they would place value and what the next follow-up test or step is supposed to help accomplish, right? And so they feel that they've made an informed decision truly.
Right. Anything that you want to add, Dr. Moore? I'm
Good.
gonna pivot. There's a question that is a very broad question, but I'm going to ask it anyway, which is, when do you think this status quo will change and we'll see adherence growing from 30%, 40% in that range to 90%? What should happen for that change to occur?
I think it's going to be based on the tipping point with AI tools and having that level of help from AI that will make that transition both cost effective and have the quality that we need to do the right thing. Basically just marrying the decision support, what should you do with it, as well as the communication and the notifications and the follow-ups.
So synthesizing reports and being able to effectively communicate those reports that should be followed up.
Right, and the actual follow-up as well.
And the actual follow-up. That's a lot of AI.
You need to have some humans in there as well, but you need to have something that facilitates it, I think, at this point.
Right. I mean, it seems that AI, most of the AI that's being focused today in radiology has been on the clinician side, right?
On the imaging side.
On the imaging side, exactly. And so more and more needs to get focused in the workflow side, which is a lot of what Agilon Health does, by the way, but this is not an advertisement. Dr. Kang or Dr. Moore?
Yeah, I mean, when you're talking about adherence, I'm mainly thinking about the lesions that, without a doubt, right, that need to be followed up. Not so much the lesions where they're, 1% or less than 1% might be acceptable risk, right, depending on the patient's health context, what other things that they're considering are priorities in their lives, and some, appropriately, again, might be shared decisions with regard to whether they want to take up, an adherence protocol, a follow-up protocol. But for those lesions where, we are concerned about the level of risk for an adverse health event, in addition to what Andrea said with, the multi-steps in terms of consistent reporting and communication and clear communication to patients to enable their involvement also. I think there are barriers to access that we have to continue to advocate about, right? There's some, convincing studies out there that even with, the knowledge that there is a lesion, patients who are disadvantaged, right, and maybe socioeconomically disadvantaged, or in neighborhoods where finding the right imaging provider or provider for clinical care is much harder to come by, right? Not to mention all the other social determinants of health that might be affecting their lives and ability to get timely care. So those are things that I think, as Chris alluded to earlier, those are things that we need to continue to measure, right, and discuss with regard to how we talk about improvement and what interventions can be, measurable successes for those kinds of challenges.
And not to be too cynical, but I mean, I think also some of the financial incentives do need to align, whether that's a business case or, Greg Nicola, who's with the ACR, does a lot of work in this area, has pushed for, considering CPT codes around follow-up, to make sure that happens. I don't know if that'll ever happen, but I think ideally, if it's enough of a quality issue, providing incentives that align with that quality is important to really making it happen.
What about
And you have to measure
regulatory?
it as well. You have to measure it and put some teeth in the quality side, right?
Right.
Right.
And I hate to sound big government, but what about the regulatory side of things? So there's obviously the Act 112 in Pennsylvania that requires imaging to be sent, reports being sent to the actual patient. Where do you all think regulation is in the context of improving adherence gap?
Yeah, regulation is a very big hammer, right?
Right.
I mean, I think sometimes a necessary step if you can't solve it in other ways. But it's time consuming, and enforcement is tough. So I'd rather see it, evolve through the right channels in terms of people being concerned about quality, and making sure it's the right thing. I think that's the better way to do it. But if it really doesn't happen, I guess that's always one way to go.
Well, what about something like the Joint Commission as an example, right? Is there a role for them in this or not?
Right. I mean, one of the quality measures we're trying to develop is, equity of follow-up. So our, the people who have insurance and, access to care getting followed up at the same rate that people who are not. So I think equity measures, certainly pointing that out, whether it's, just doing that publicly or having some teeth, as Andrea is suggesting. I do think that if we care about something, making a quality measure around it is certainly very feasible. And that's, also something that the regulatory agencies can look at.
Yeah, from the standpoint of the Joint Commission, I was just on a webinar with NCCN where they were talking about screening for social determinants of health, and they did have someone from the Joint Commission on there who said that, they do have quality measures, but when something new comes up, for example, the screening for the social determinants of health, they try and make it sort of more of a general approach so that people can catch up and develop the capabilities to meet the new requirements. So I would think that having the Joint Commission maybe say you have to track adherence would be the first one, is just a measure just to track. Once you start tracking something, then you can take a look at where the gaps are, and then you can take a look at what you need to do to address them.
Yeah. Do you know, not to put you on the spot, Andrea, but do you know how effective Act 112 has been in the context of helping patients advocate for themselves and to help close that adherence gap?
No, I don't know.
Okay.
Anecdotally, I know that patients patients want to access their patient portals. If you take a look at some of the Pew research, it shows that about 40 to 50% of patients access their portals, and they really want to look for their test results as the prime thing that they look for. So I think it's important to patients, and patients want to have that stuff delivered to them directly. There was a recent journal article that came out, and I won't remember the details of it, but basically they did a survey of people having access to their radiology reports, and 94% said they absolutely wanted access immediately, even if it was bad news.
Yeah. All right, we're going to have to wrap up here. Any closing thoughts that you all have, Dr. Moore, Dr. Kang, Andrea, anything that you want to communicate to folks in the audience?
Just wanted to thank you for bringing this together. And Andrea, it's particularly refreshing to have such an educated patient advocate as part of this. It's such a huge part of the the whole thing. I mean, it's great to be here with Dr. Kang as a radiology, and then, industry also has a role here for finding solutions that, academia is not able to put together yet. So thank you for bringing it together.
Yeah, sorry, go ahead.
Yeah, I mean, I'm also appreciative of being here with Dr. Kang and Dr. Moore. I mean, I'm really thrilled that people are focusing their research and looking at ways to close the gap in actionable incidental findings, because I think it's a harm to patients. So anything we can do to improve it. And my closing thoughts are sort of my same theme. Make sure we include the patient, make sure we meet the patient where they are from a language standpoint, and really help involve them in the care, because it will help close the gap if we do that.
That's right. That's right. I mean, I want to further that, because that's exactly what I was thinking, is that more likely than not, all the parties involved, all the stakeholders clinically and on the patient side, and also from the perspective of health systems leaders, probably have more in common with regard to the goals, right, around actionable unexpected findings and differences. And so just to engage each other and to come up with a systems solution that works locally is really the way that we need to go.
And I think that's a really great way to sort of end the webinar, which is, we really are, the purpose of this webinar was to bring the key diverse backgrounds that are required for us to improve adherence rates. So somebody who's a referring provider, somebody who's a radiologist, somebody that's an advocate for patients. And that's why I was so excited to do this with you all. And so thank you each for your time. Want to thank the audience as well. We've spent the past hour discussing adherence challenge and haven't mentioned anything about Agilon Health. We had a few questions specifically about Agilon Health and how we approach the market. I didn't mention these questions because this is not about Agilon Health. This is about educating the market. That said, if you're interested in learning more about what we offer, we have a link in the chat window to contact us for an introductory call. So I just want to mention that. We're also going to send the webinar out. It's been recorded. So we'll be emailing it to you all, the registrants. And till next quarter, let's continue doing the right thing by patients. So have a great 90 days, and we'll speak to you next month or next quarter.